morning everyone. I would like to welcome you all today for our 19th morning CME session. And first of all, I will request you all to stand up for doctor's prayer.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामया सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् न त्वहं कामये राज्यं न स्वर्गं न पुनर्भवं कामये दुःखताप्तानां प्राणिनाम् आर्तनाशनम्.
Good morning everyone. Once again a very warm welcome to this 19th CME session of GP Association. And today's session focuses on a very important and highly relevant clinical topic, and that is medical management of pancreatitis. This condition, though frequently encountered in our day-to-day practice, continues to pose diagnostic and therapeutic challenges. And we are fortunate to have with us a highly experienced and knowledgeable speaker who will guide us through the latest protocols and practical aspects of managing pancreatitis. It's my privilege to introduce our esteemed speaker, Dr. Pankaj Kumar, a highly accomplished gastroenterologist. Dr. Pankaj has completed his MBBS and MD in General Medicine from GSO Medical College, Kanpur, and went on to pursue DM in gastroenterology from the prestigious SGPGIMS, Lucknow. He has served as a senior resident at several renowned institutions including STM Medical College, Haldwani, GSO Medical College, Kanpur, GB Pant Hospital, New Delhi. He has contributed to a significant research in the field with publications focusing on non-alcoholic steatohepatitis in type 2 diabetes, JAK2 mutation in HVOTO, and minimal hepatic encephalopathy in portal venous disorders. Currently, he is serving as a consultant at the Gastro Liver Clinic in Gorakhpur, where he continues to advance care in digestive and liver diseases. So now I request Dr. Pankaj to please guide us through this topic. Thank you.
When I got the information, it's pancreatitis overall and the management part, but pancreatitis is a very vast topic, and every aspect itself a whole chapter. Even though some conferences hold on the pancreatitis and each and every it came 2-3 days to cover all the topics. But what the most important thing for our day-to-day general clinical practices, so what the pertinent points. So I have covered some of that point, and because when the complications occurs, most of us or in general practice, they tend to refer to the patients to heart center. So important point is the first 2 weeks of the pancreatitis, because that time the inflammation and the inflammatory response which we have to tackle, in most of the cases is settled down to itself. But when the complication occurs, definitely some expertise needed and the well-equipped infrastructure is needed to deal with that. So we will focus on the first 2 weeks part, where in general how we can manage in best way to get the best result out of the acute events. So in general, what the acute pancreatitis, what is the epidemiology? The most common, one of the most common GI causes of hospitalization. So global incidences ranges from 13 to 45 cases per lakh. Now the incidence of acute pancreatitis is steadily increasing over the course in the most of the countries. Maybe because of the alcohol intake itself is getting increased in the population. But what more important is the mortality is high in the low socioeconomic conditions. Low socioeconomic condition means the infrastructure of the medical facility is not available. So that's why the mortality is high in low socioeconomic countries. So how to diagnose acute pancreatitis? Everyone knows the typical abdominal pain which is radiating to back, severe excruciating pain, and along with the elevated enzymes levels, serum lipase and amylase, more than 3/4. That's the two pertinent things we can diagnose easily with the help of any imaging condition which tells readily what the diagnosis is. So any of two of these features we will diagnose acute pancreatitis. So outside I would like to say we will talk in recent and the particular headings we have characterized the particular sets where we can utilize our clinical knowledge to manage the patients. So these are the risk stratification and monitoring, the fluid resuscitation therapy, because it's a big confusion was going on with what fluid should be given, how much is given, how much the rate. Then the symptom management, of course, use of antibiotic. Again, this antibiotic use is a big, because all the academicians say there is no need of antibiotic in the initial 2 weeks. But in the general practice, the day we patients land up in the hospital, he given the most highly potent antibiotic. So what are the current uses and how can we use judiciously to antibiotic use particular patients? Then there comes the nutrition part. When the complications occurs, how can we deal with that? There is a minimal invasive techniques and there are the surgical. So what the important point is that despite all the initial strategies, 1/5 or 1/4 of the patient develop local complications. And when the patient develop local complication, which is the most dreaded, is the infection. So infected pancreatic necrosis is the most dreaded complication, local complication, which happens late in the course after 2 weeks. The initial complication which is dreaded is the organ failure. The first 2 weeks we have to look for the organ failure, and if it resolves, the patient settle very well. If it is not resolved, land up in the complications, a different story. After 2 weeks, what are the most common complication is the infective pancreatic necrosis. So how do we do with the clinical course? Assess the clinical course. Various criteria has been defined. And the most recent one is the revised Atlanta criteria, which define the phases of pancreatitis, acute pancreatitis, and then severity of the acute pancreatitis with the help of radiological diagnosis. So why the phase of acute pancreatitis is important? So in revised Atlanta classification, it has been divided into 2 phases, early phase and the late phase, because it's pertinent clinical problem. Early phase is predominantly the inflammatory response which governs the whole clinical scenario. So the systemic inflammatory response present in the most of the patients, and this systemic inflammatory response predisposed to the organ response. So we have to monitor on these parameters, and definitely the organ failure monitoring, respiratory, cardiovascular, and the renal, which occur in due course. The late phases is predominantly governed by the local complications and the response related to local complication. So what we have the local complication, we can have the necrosis, an ongoing necrosis, then patient develop infection in those necrotic part, which is the infective necrotic pancreatitis, and then if the particular organ is not supporting well, is the organ failure, then we need to have the organ support, and simultaneously after 2 weeks we need to have supplement nutrition part, because the pancreatitis itself is a very catabolic disease. So after first 2 weeks there is a definitely need for the nutrition to sustain the ongoing inflammation and injury in these patients. Now the second part is after the phase, which is important, the severity is also important. So everyone knows that there is a 2 category which has been divided, the mild acute pancreatitis and the severe acute pancreatitis. Mild, when there is a no organ failure. Patient may have the heavily elevated amylase or lipase, severe pain, but there is no organ dysfunction. So we have to judge whether the oxygen saturation is well, vitals is maintaining, is passing urine output. These patients characterized into the mild acute pancreatitis, and there is no local or systemic complication is there. And then in between the mild and acute, there is a moderately severe acute pancreatitis, in which the initial course which occurs, there is some sort of organ failure symptoms are there, whether the creatinine is raising, urine output is down, whether the patient is need support or some oxygen support or even in the ventilator support, but it rapidly abolished and the organ is resumed its function. That's the criteria. Is if the organ failure resolved within the 48 hours, we can take as the patient have developed the acute pancreatitis, severe form, but it is recovered. So we take the term moderately severe acute pancreatitis. And then the last severity is the severe acute pancreatitis, where the organ failure is persistent more than 2 days. It can be single organ failure or the multi organ failure. So and this is the characteristic. Now, how we judge the severity? So, severity is judged by the age, the comorbid features, obesity, and these are the general physical parameters, and severity is also judged by the inflammatory response. So, till now, various critical management, various scores has been devised. There is Apache 2, BICEP, hematocrit, and the BUN, but none of them has actually changed the course, even with how much severe criteria we take. But ultimately, we have to judge on the basis of what the inflammatory response is there. So, if there is a persistent hypotension or there is a oxygen desaturation, these are the two important things, and definitely the organ, the routine parameters, what the organ is behaving. So, systemic inflammatory response in features are still the most objective to judge the patient day-to-day monitoring. So, I already discussed that various scores has been devised. The patient which has the severe acute pancreatitis, enter with the ICU, what criteria should be followed. But none of these criteria has clearly superior or inferior to the SIRS, which is the systemic inflammatory response syndrome, which is the simple, whether the patient is having high grade temperature, more than 38 degrees centigrade, there is a hypotension, the blood pressure, the systolic blood pressure is less than 90, and the hypoxia. So we have to judge basic parameters, whether the inflammation is ongoing. Which patients we do put needs critical care. So if the patient is having pulse rate below 40 or bradycardia, the patient having tachycardia, if the pulse more than 150, and the systolic pressure is less than 80, or the mean blood pressure is less than 60, or the mean diastolic arterial pressure more than 50. So these are the criteria which can judge, and these types of patients require ICU therapy. So even the clinical parameter and the investigative parameter, when the patient develop hyponatremia or severely hypernatremia, hypokalemia, so much so, and that then the oxygen saturation is falling below. These are the clinical parameters which we need. The patient needs ICU, immediate ICU admission. Now these are the clinical parameters and biochemical, and what are the radiological parameters for which we have to think of. There is an imaging importance of imaging. So acute pancreatitis, we need to do the imaging. So what are the time? It's also important. Not the first day we need to do the CT scan. Usually it's at 5 to 7 days, because at that time, so most of the time the necrosis part has been well developed. For the initial phases, the necrosis part is not developed. So, and the day to day, the clinical parameters are changing. So what we are getting from the imaging, we are getting whether the pancreas is necrosed or not. So these are the important things. Pancreatic necrosis is the very important for imaging point of view. So we do the IV contrast, and the pancreatic parenchyma itself, if well enhanced, it means the vascularity is well maintained. And if there is a necrosis in that particular area, there is no vascularity. So this is a very basic definition. So what we are getting from the CT scan, whether the patient having the pancreatic necrosis or not. And other things, whether we are getting any local complication along with the necrosis. So we have the enlarged pancreas, we have the peripancreatic inflammation, fat stranding, we can have the fluid accumulation with acute fluid collections. Then certain cases in the injury part, pancreatic transactions, ascites, we can also can see the various fascias. We can have the pleural effusion. So we all these get. What are the important thing is that what we are need to see. Two most important things. First is what is the status of the pancreas necrosis, and what are the complications. So we have to see on this acute pancreatitis. So just like that, this is simple interstitial pancreatitis. So we see the pancreas is well enhanced throughout its length, but there is a inflammation surrounding. So these are the peripancreatic inflammation. In this case, we don't see any local complication apart from some fat standing in the vicinity. The pancreas is well enhanced, so it's just pancreatic enlargement, and there is a peripancreatic inflammation. Now see the second picture. here the pancreas is getting necrosed, and we see some hypodense area within the pancreas, so we can judge the whole of the body and the pancreas is getting necrosed. This is important. That now we can see easily that the necrotic part is more than 30%, so it's a severe part. Then we can have the local complication in form of fluid collection or pseudocyst. So initial 4 weeks, any fluid collection which are labeled as acute pancreatic fluid collection, because it's do not have the boundary. There is a fluid excavation along the fascia, what are the local fascia is available. So we can have the fluid collection in the lesser sac or in the pancreatic spleno ligaments. There is a fluid collection. It doesn't have any boundaries. But as gradually the inflammation settles, because of the inflammation, the inflammatory boundaries is getting evolved. And when the inflammatory boundary is getting evolved, then there is a definite pseudo collection or pseudo membrane is there, and now the patient have the pseudocyst. It's a false inflammatory membrane around the collection. So these are the local complication, late local complication. So what we are getting from the imaging techniques? First, we have to see whether the pancreas, how much is already necrosed, or what can be the local complication is there. So we have to deal with both the things. Now, when the inflammation is ongoing and the patient having persistent inflammation and the persistent necrosis is going there, so the necrosis is not only limited to the pancreas, it is also evolving across all the tissues. So we have the necrosis and there is evolving. And apart from the necrosis, we also see the whether air pockets are there or not. So we can say that the organism, infected part is there. How can we judge whether the necrosis is purely inflammatory or there is an infection? So signs of infection, if there is an air pocket is developed within the inflammation, so we can judge there is a air forming bacteria is there and the patient is suffering from infected pancreatic necrosis. And second also, if there is a dilemma between the sepsis or the infected pancreatic necrosis, we can just FNA from that site and we can do the culture and all this thing, getting whether the bacterial infection is present or not. So the fluid collection, when it evolved into the pseudocyst. When the necrosis is evolved during the course, is developed into the wall of pancreatic necrosis. So two terms are very different and salient. Simple fluid collection gradually evolved to pseudocyst in due course. Infected pancreatic necrosis going to evolve in the wall of pancreatic necrosis, and the management is different in those cases. So what are the CT criteria for severity? So we take the first is the inflammation and second is the necrosis. Necrosis, initially it was divided into 30%, 35, 30 to 50 and more than 50. But now what is the modified CV severity index is pancreatic necrosis, there is a none. If less than 30, we take a score as a 2. If more than 30, we take as a score of 4. And for the pancreatic inflammation, if the pancreas is normal, score is 0. Any pancreatic abnormalities, whether the peripancreatic inflammation or small fluid collections, we take as a score 2. And the pancreatic fluid collection and the fat necrosis around the, we take a score of 4. These are the local scoring, and if there is any systemic complications such like pleural effusion, ascites, or the any GI tract involvement just like the ileus, we add on a score of 2 also. So the severity index is more than 5, it shows the high mortality. And the modified criteria is which has divided into 3 parts. If less than 2, mild, 4 to 6 is moderate, and 8 to 10 is the severe. Now in the management point. So what the most important thing is how much fluid should be given. It's a very pertinent question, all of us. If the pancreatitis patients come to us, what fluid should be given and how much amount would be given, what are the infusion rates. So what are the initial thoughts? It was thought that it's a very extravasation fluid was much high. Initially it started 10 to 12 liters, Subsequently, moderate is 8 liters, 6 to 8 liters has been lost due to the pancreatitis. But most important thing is the presentation in the hospital is from the onset to the presentation. That's a very important thing. In earlier days, where the medical facilities are not available so much, the patient developed pancreatitis and due course over the 8 hours or 10 hours when the patient present to the hospital. And in those days, because of the persistent vomiting and there is a persistent necrosis and extravasation, that time it used to be there is a lot of fluid is in the third space and the patient is high volume depleting. So in those days, the high volume repletion therapy has been devised. So high volume was given in that time. But gradually the medical facilities evolved and now the concept has totally changed. So I am put at the one study where the aggressive fluid versus moderate fluid resuscitation was studied in these patients. The number was around 250 patients. So it has been randomized into two groups. One is the aggressive fluid resuscitation was given, other is moderate fluid resuscitation was given. So what the aggressive criteria was that the bolus of 20 ml per kg bolus, and then the infusion rate is around 3 ml. So if the bolus is 20 ml per kg, it's mean of 60 kg of patient. So it's mean around 1200 ml or 1500 ml immediately, and per hour is 200 ml per. So it's a lot of volume is going on in this aggressive fluid resuscitation. But now change has been gone to moderate fluid resuscitation, where the infusion only to 1.5 ml per kg per hour. It's mean around 100 ml per hour, and bolus only if the patient have signs of hypovolemia. So there is a concept of bolus is not surpass all. When we see the patient is hypovolemic, give the bolus. Otherwise, maintain the moderate fluid resuscitation throughout the course. So what are the changes we had seen? We find that there is no difference in the clinical outcome, whether we go ahead for the aggressive fluid resuscitation, whether we go ahead with the fluid resuscitation. So definitely the aggressive fluid resuscitation is not benefiting in any way. Overall, those patients which have given aggressive fluid therapy, they found that there is a much more complication, 3 times much more complication like overload happened in the aggressive fluid resuscitation group rather as compared to the moderate fluid resuscitation. So this is a recent study. So it has been established that moderate fluid resuscitation seems to be preferable over the aggressive approach. Now the second thing is various guidelines say how much fluid should be given or how to monitor. So it has been devised that goal-oriented intravenous fluid therapy 5 to ml per kg per hour should be initially until the resuscitation goals are reached. So what are the resuscitation goals? The patient heart rate is getting down below 120, mean arterial pressure is maintained between the 65 to 85 mmHg. If urine output is more than 0.5 ml per kg per hour, one has decreased, hematocrit has come down below 44, and some imaging criteria like ultrasound guided IVC diameter, if getting the IVC is less than 1.5 centimeters. So these are the criteria where the volume depletion is achieved. But even the various controlled trial, randomized controlled trial failed to show any significant improved mortality prevention on the basis of goal-directed therapy. So what we have to assess that we have to judge patient by patient how much the patient is, his vital parameters are. The patient is having hypovolemia, you can give the therapy. You can assess the urine output monitor, you can assess the heart rate and all this thing, and inflammatory response symptoms. So moderate fluid resuscitation therapy is the most important rather than the aggressive therapy. So this concept has been changed totally over the course of time. Another thing is we should know what are the most important fluids should be given. So ringer lactate has been evolved as a predominant choice. So it has been postulated why ringer lactate is important. That it has shown that it has some anti-inflammatory capabilities. It seems that ringer lactate has much is better than the other fluid for the pancreatic. It resuscitation inside the pancreas. It's better access to the pancreatic inflammation. So it has been evolved throughout that the ringer lactate is the most important fluid for the initial resuscitation. So how do we monitor fluid response? So we have to assess every 6 hours to 8 hours for the vital signs like oxygen saturation, vitals, blood urea monitor, urine output. If the patient having the hematocrit is decreased, the burn is decreased first 24 hours, so it suggests there is strong evidence that the sufficient fluid has been administered. But in those patients which have the cardiac or pulmonary or renal disease, we have to be cautious about the fluid therapy. So we have to cut short the fluid therapy in those patients according to their parameters. And then now the other clinical parameters or the investigatory parameters is important. Apart from this, we have to do the 2D echo. We can, if the patient in critical condition, CVP again the important things we have to do. If the CVP low, you can judge according to how much fluid should be given. If CVP is high, then we have to judiciously use the fluids in those groups of patients. Now again pertinent question is the antibiotic and acute pancreatitis. So first and foremost thing, acute pancreatitis within the 2 weeks of duration is a predominantly inflammatory disease. It's not an infectious disease. So the starting with the antibiotics day one is not in a judicious way is important. Unless until the patient having any septic complication or the septicemia, we have to see. So how can we judge the patient is having septic complication or the just inflammatory response? So in nutshell, the pancreatitis itself is a inflammatory problem within the first 2 weeks of period. So antibiotic have not been shown any substantial benefit, but it has exposed the patient to the risk of adverse effect like the development of resistant microorganisms. In due course, when the patient is admitted in the hospital, various secondary infections do occur in the hospitals. In our scenario, we see that lots of nosocomial infections there. So how can we assess this basic question, whether should be antibiotics should be used or not? So there is a study. It's very important for the clinical point of view, which has shown if we can use the procalcitonin level as a marker of infection, that can give this answer to our question. So the patient went land up in the hospital. First 2-3 days, definitely there is no risk of infection. After 2 days, we can assess procalcitonin level. The normal level in procalcitonin is 0.05. If more than that, then we can suspect the infection. 0.05 to 2 is, we can judge there is some local infection. If procalcitonin is more than 2, definitely there is a systemic infection. Now can we use the antibiotic of our choice in those groups of patients? So what are the antibiotics we should give in? It should be broad spectrum, because the most of the time is a gram-negative bacteria. So should be broad spectrum antibiotic. Is also the hospital-based antibiotic. Everyone is judging in which hospital, what are the combination of drug usually given to the infected patient. So that can be given. So the antibiotic from the first strand is not recommended. If you suspect infection, go for the procalcitonin level. If it is high, then go for the antibiotics. It's a broad spectrum antibiotic. Otherwise, general antibiotic covers the initial first weeks is more than sufficient. Now the nutrition part, it happens in the second phase of pancreatitis, the more than 2 weeks. So the initial point of view, the patient kept NP, general practice, routine practice. So how much early we can start the oral therapy or the gastric feeding, that's important. As soon as the patient tolerate the feed, we should give in the oral feed. This is very important because it has been shown the early enteral feeding maintain the gut barrier integrity, limits bacterial translocation throughout the GI tract, and is very less expensive. As soon as the patient can tolerate the feed, we should start the oral feed. Early enteral feeding also decreases the risk of infection, length of hospitalization, and overall mortality. So the first initial maybe 2-3 days we can keep the patient NPO, but after that the patient pain has subsided. The patient can tolerate. We should start the oral therapy. The usual practice is keep NPO for the patient for long, at least 1 week is not recommended. As soon as the patient can tolerate, start the oral. Now, what form of feed can be given? Is simple, low fat feed, predominantly the carbohydrate feed. Whether should be given orally or by the nasogastric tube, because most of the time the usual practice is put the rice tube in the straight forward in the first instance. So we can judge if the rice tube and the output is nil, patient is not having any vomiting, patient can tolerate the feed, we can start the feed. So it has been shown that oral feed versus nasogastric feed, we find there is no difference. So oral feed is better than whether the nasogastric feed or the nasogestrel feed. These type of therapy, nasogestrel feed, we do require in those patients which has the local complication. Just like severe pancreatic inflammation, so the duodenal compromised, in those patients we should put the nasojejunal tube for the feeding purpose. So the important thing of this particular point of impressing is start oral feed as soon as the possible. 2 points we have to see whether the patient can tolerate or whether the ileus is present or not. Simple, if the bowel sounds are there, patient can tolerate, start oral feed as early as possible. There is no time limit. Even in the milder case, the inflammation subsides within a day, so we can start the oral therapy by the next day. But we have to judge by clinical parameters. Now those patients we have the severe form and there's some sort of organ failure, on which we have to support the organ and for the monitoring for the complications. So for the symptomatic management, pain management is very important. We have to give the narcotic analgesics. Usual thing we use the tramadol. We can give the bolus dose or we can use in the infusions. What if the patient is not responding to this? Simple tramadols. What should be the next? So next should not be the NSAIDs in a pertinent way. You can give the NSAIDs 1 or 2 stat basis because the severe pain is there. If patient is not responding to, better to increase to the bupivacaine or some other narcotic analgesics. So bupivacaine patches are available is there. So simply put the patch along with the tramadol. SOS based NSAIDs or Dynapar can be given. So most of the time the pain subsides by itself. Respiratory care, every patient should be given the oxygen by nasal cannula and the oxygen saturation should be maintained over the 90%. What are about the metabolic complications? Hyperglycemia occur most of the patients for the first several days in these patients of severe pancreatitis, but usually it disappears as the inflammatory process subsides. So blood sugar fluctuates in the initial course. So in those patients which have very high sugars in the initial course, insulin therapy should be administered in those patients. Hypocalcemia can occur predominantly because of the low serum albumin. So hypocalcemia is largely usually remain asymptomatic, and these hypocalcemia require no specific therapy. So these are the general management. And what are the etiology specific management? So the two important things are, one is the alcoholic pancreatitis, other the gallstone pancreatitis. In the Western world, where the alcohol is socioeconomic well established, so everyone is most of the time, male or female, taking alcohol. In those of patients, we can have some confusion, but in our Indian situation, we don't find any confusion. The patient have gallstone pancreatitis or alcohol-induced pancreatitis. Clear-cut history is there, so we don't have a many dilemma. But in that case, if the patient having alcohol and on a regular basis, and also have the gallstone, what else should be the etiology? So we can judge by if the patient, for the initial presentation, if the SGOT, SGPT is raised, so we can think of that this should be the alcoholic pancreatitis is the most one of the leading cause rather than the gallstone pancreatitis. But in due course, we see that itself is the etiological is not very confusing, because if the patient is presented with the pancreatitis or not. In Indian scenario, most of the time gallbladder stones has its own complications. So we do recommend the cholecystectomy, whether if dilemma is persist, whether there is alcoholic pancreatitis or the gallstone pancreatitis. Gallstone is there, patient land up into pancreatitis. What the most of the in our situation we suggest or recommend that gallbladder surgery has to be done. For the gallstone pancreatitis, whether because the initial we see that the change in the liver parameters is deranged. So most of time is thought that this is whether gallstone is passed into CVD or not. Whether the CVD stone is there, where should go for the ERT is still a pertinent question. So biliary pancreatitis, we have to, once the inflammation subsides, the patient is evolved, early cholecystectomy is recommended. For the mild pancreatitis has been recommended, we can go ahead for the cholecystectomy with the same hospitalization. But for those cases of having the severe pancreatitis, we have to give the period to the inflammation to be subsides, and we can recommend cholecystectomy after 4 to 6 weeks. The other etiological thing is the hypertriglyceridemia, where the triglyceride is more than 1000. So still there, the focus should be on the sugar management rather than the hypertriglyceridemia. So the initial general management remains the same. We have to, most of the time is in patients with the diabetes, these happens. So the focus is still on the sugar management rather than the triglyceride management. Once the patient has subsided the inflammation, then we can use the lipid lowering agent in due course. Other etiology of the pancreatitis, just like hypercalcemia or post-ERCP pancreatitis or drugs is there. In those patients, hyperparathyroidism, hypercalcemia is there. So calcium reducing agents can be given. Post ERCP pancreatitis itself most of the time it's happening in all patients of ERCP, but it is very mild or subtle, we can't judge. In simple ERCP, if we do and we judge the serum amylase monitoring, we find there is a amylase level below 250 to 500 is usually up. So mild pancreatitis is usually there if we judge by the amylase. But sometimes it's land up to the various serious pancreatitis. And important point of thing is that post-ERCP pancreatitis, if it happen to be severe, it doesn't give any time. Within 2-3 days, it evolves in such a rapid course. Most of the time, we can do nothing as compared to the normal pancreatitis. So the complicated, because of pancreatitis, ERCP, the most dreaded complication, and the mortality in those cases is very high. So within 2-3 days, the inflammatory response is so much severe, so we can't solve the patient most of the time. So though the ERCP is rapidly occurring, the complication is still there. So what we can salvage these patients? Before the ERCP, give the indomethacin rectal supplement. So it is very important. Anti-inflammatory agent before ERCP, rectal indomethacin is very much important. It has been reduced the incidence after the post-pancreatitis in a very much great manner. And again things, during the ERCP, if any chance the pancreatic duct cannulation occurred, the wire goes into the PD rather than the CVD. First instance of wire going to the PDs, we have to put the PD stent straight forward. We don't try that leave it at such and go other for the CVD. We cannulated by chance PD. If we PD had cannulated, we have to immediately stent the PD. If we follow these two parameters, almost severe pancreatitis after the ERCPs has been almost average. So these are too important to salvage the patient. After the ERCP, if pancreatitis happen in severe form, is not going to give any chance. So it's a very serious complication which can dealt with the effectively, preemptively. Before the ERCP, we have to give the indomethacin enema, and during ERCP, if PD cannulated, immediately PD stent has to be put. So What are the complications of acute pancreatitis? It can be local or systemic. Local complication, it happens in the peripancreatic inflammation, peripancreatic collections. There is a pseudocyst formation. There is a wall of pancreatic necrosis. In some cases, disruption of pancreatic duct. Because of the disruption, pancreatic ascites can happen. Because of the inflammation, subsequently the thrombosis of the vicinity vessels like splenic vessels, superior mesenteric veins or portal vein can thrombose. Because of pancreatic inflammation, gastric outlet can happen. And sometimes, because of the inflammation itself, the biliary obstruction is there. The patient develops into cholestatic jaundice. What are the systemic complications? We have the pulmonary, that most of the time is the infusion, sometimes is respiratory distress syndrome, cardiovascular events because of the hypertension, and then the DIC is there, the renal complication, we land up in the renal injury, renal dysfunction, subsequently the renal failure. We can have the complication like GI hemorrhage because the splenic artery aneurysm or gastroduodenal artery aneurysm, which are the vicinity in the pancreas, it happens so fast and the patient land up into severe torrential type of bleeding in due course. And then we have the metabolic complication. The most important in general, what are the local complications which happen? The pancreatic necrosis is the most important because pancreatic necrosis, if happens, it definitely going to with the local complication. If the necrosis is limited below 30%, most of the patient recover within the 2-3 weeks. But if the necrosis is high, we have to judge by initial 2-3 first weeks. If necrosis is high, then most of the time these types of patients land up in the local complications, just like walled off pancreatic necrosis, infected pancreatic necrosis. And if the patient land up in these two group, definitely the course going to be very long, persistent, and we have to monitor or treat the patient in long-standing way. So sometimes we have seen if the pancreatic necrosis is there, infected pancreatic necrosis, patient put into ICU, keep 3-4 months during the hospitalization itself. So it's a long-driven complication. It's not going to resolve easily. You have to do a lot of things, continuous antibiotic support, continuous organ support, and the patient is most of the time is not salvaged in due course of time. So the important thing whether the necrosis itself is infected or not is a very pertinent thing we have to judge. By clinical we see the patient is running fever, signs of septicemia, leukocytosis, and important we have the procalcitonin in our hand to judge. Second thing, how can we diagnose confirmably by the US guided FNA or the CT guided FNA. And once we have seen or diagnosed there is infective pancreatic necrosis, we have to treat. So if there is a necrosis which is infected, first formation is there, we have to treat. Now question is, the patient is having the long course complication course, and we can diagnose there is infective necrosis going on. How go ahead with these types of patients? So then again, it has been shown that the minimal invasive techniques are much more important than the open surgical techniques. Why? Because it gives the less morbidity and mortality. So what option we have? We have the percutaneous catheter drainage, like PCD. We can have the endoscopic drainage of necrotic material. We have direct endoscopic necrosectomy because we have to clear all the necrotic part and infective part, and we have minimal invasive surgical necrosectomy. So these are the options for the infected necrotic pancreatitis. So how do we approach these patients? We find that the patient is land up into the infective complication. So first we have to try that the conservative management. It has been shown that if we do not touch these patients, if the patient is giving the time for 4 weeks, most of the time the patient settle by simple conservative measure of antibiotic and all the supportive management. Even after the 4 weeks, the infective complication ongoing, then we most time to time use the any intervention to drain the particular infected segment. So again, the criteria of duration is very important. First 4 weeks, we mostly use conservative management, and after 4 weeks, the patient is not responding to antibiotic, not responding, and the organ is ongoing in a critical way, then we have to land up into the some sort of invasive therapy to drain the infected material by the PCD or by endoscopic manage. And if at all not responding, surgical necrosectomy can be done. So these are the various studies has been. So and just these are the basically various studies in which the necrosectomy has been studied between the minimal invasive, whether the endoscopic or surgery. It has been found that the minimal invasive techniques are much more better than the surgical necrosectomy in due course, because mortality is low in minimal invasive techniques. So I'm not going into detail of these studies. The important thing is again I have said the delayed rather than the immediate intervention is superior to for the pancreatic necrosis, regardless of the specific treatment modality. So first 4 weeks we have to manage the patient conservatively most of the time, rather than going into the early surgical or endoscopic management. So these are the simple things. The PCD placement for pancreatic necrosis. There's the endoscopic technique when there's a wall of necrosis there. Through the endoscope ultrasound, we just the cavity of infected, the pseudocyst or wall of necrosis. We puncture that and put a metallic stent. This is the lamps nowadays, and there is a big stent placed between the stomach and the lesser sac most of the time. So all the infected material drain into the stomach and then passes out. So very minimal invasive techniques. It gives better results. Then we have the nasocystic duct placement. We use plastic stent between the stomach and the cyst. Again, the ERCP again pancreatitis we already discussed. Whether should be ERCP go ahead with the first instance or not? This is an important thing. If the patient having ascending cholangitis, then we have to go the ERCP in urgent manner. If the patient is not having ascending cholangitis, just manage conservatively by just like any other pancreatitis, and when the inflammation is settled, then of course we go ahead for the ERCP. What are the features of ascending cholangitis? Is the severe inflammatory response because of cholangitis, because of jaundice, severe pain and infection. And imaging technique we show the dilated CVD. So if these are features say there, we go ahead for the ERCP in urgent way. Otherwise, just presence of CVD calculus inside the CVD doesn't mean that we have to go urgently for ERCP. Post ERCP already we have discussed. The important thing is the endoscopic ultrasound in acute pancreatitis. The important thing is that if we have a dilemma, is there CVD stone or not, we can choose this method. It's better result in these critical patients. And whether there any material has to be taken, by US we can take the material very well. So what are the promising therapy in future? Basically we have to tackle the inflammation part. So various promising therapy which tackle the initial inflammatory response has been ongoing in the studies. This IL-6 receptor antagonist, statin abrogate and the lipase inhibitor. These are the where we can the initial nidus we have to, because the inflammation has to be controlled. The studies ongoing that if we happen to have if the inflammatory response has been cut down in initial way, these are the groups of therapies we can involve and better result in our pancreatitis patients.
Thank you, Dr. Pankaj, for such a comprehensive, insightful and illuminating talk. I'm very sure that everyone has taken their takeaways from today's for their better private practice. So Before moving to the Q&A from audience, we'll go for the short quiz. I request Dr. Pandey sir, please conduct the quiz. So again, there will be 5 questions. First question from that left side and the second question from right side. You have to raise your hands. Dr. Pandey will select the candidate who will answer the question.
Fifth one will be common.
Fifth one will be common. So the first question is, which of the following is not a component of the revised Atlanta classification of acute pancreatitis? Option A, interstitial edematous pancreatitis. Option B, necrotizing pancreatitis. Option C, pseudocyst formation within 24 hours. Or is it option D, organ failure classification? You just have to raise your hand. Dr. Bhatt. Option C, pseudocyst formation within 24 hours. My God, that is the right answer. Huge round of applause for Dr. Vatsal. Moving to the second question from this side. Which imaging modality is most sensitive for detecting pancreatic necrosis? Option A, ultrasound abdomen. Option B, contrast enhanced CT scan. Option C, MRI with MRCP. Or is it option D, ERCP? Just raise your hand. Dr. Pandey? Contrast enhanced CT scan. That is the right answer. A big round of applause for Dr. Shivshankar Shahi. Great. So the third question is from this side, which of the following is a major risk factor for post-ERCP pancreatitis? Option A, age more than 60 years. Option B, use of NSAIDs before procedure. Option C, female gender with suspected sphincter of Oddi dysfunction. Or is it option D, dilated CBD more than 10 millimeter? Just raise your hand. Dr. Chandra sir. Age more than 60 years? I'm very sorry sir, that's not the right answer. So, anyone from that side? Dr. Jaiswal sir? Female gender with suspected sphincter of Oddi dysfunction? Yeah, that's the right answer. Dr. J.P. Jaiswal sir. Huge round of applause for sir. So moving to the fourth question. Which cytokine is most implicated in systemic inflammatory response in acute pancreatitis? It's not the easy one, right? Option A, IL-2. Option B, TNF alpha. Option C, IL-10. Or is it option D, IL-17?
इन्होंने IL-2 अल्फा दे रखा होगा मगर वो TNF अल्फा इज राइट आंसर तो उसमें दे रखा.
That is the right answer. A big round of applause for Dr. Srivastava sir. So, this is the common. Anyone can raise their hand. Infected pancreatic necrosis is best diagnosed by. Infected pancreatic necrosis is best diagnosed by option A, blood cultures. Option B, serum procalcitonin. Option C, CT guided FNEC. Or is it elevated amylase and lipase?
आंसर से कन्विंस नहीं.
Sir,
मैं आंसर से
कौन?
उधर का है भैया.
Dr. Rishabh?
मैं आंसर से कन्विंस नहीं हूँ. मैं आंसर से कन्विंस नहीं हूँ. प्रोकैल्सिटोनिन इन्होंने बताया हुआ
CT guided culture.
The correct answer is CT guided supineural aspiration. That is the right answer by Dr. Rishabh. A big round of applause. So,
The procalcitonin was
एक्चुअली प्रोकैल्सिटोनिन बड़ा कंफ्यूजन वो वर्ड है और इसके लिए कभी अलग डिस्कशन होगा तो मैं इसके बारे में.
I am not giving the confusing term. What I am saying that whether to use antibiotic in that scenario is not for the general practice. So if you use the procalcitonin as a marker of infection, we can use higher antibiotic dose groups. Otherwise, we have to manage conservatively.
My question is not that. Actually, procalcitonin is a synonym for septicemia. ये लिया जाता है और ठीक है हॉस्पिटल वर्क हम लोग उतना नहीं करते हैं मगर इवन देन procalcitonin should not be a absolute marker for septicemia या infected site.
I'm not it's an absolute marker. Whether should we use antibiotic for one instance or not, that's the important thing. For pancreatitis, go ahead with the first hand, all the strong antibiotic from the day one, whether it is judicious or not. How can the general practitioner judge?
इसीलिए तो कह रहा हूँ प्रोकैल्सिटोनिन को मार्कर क्यों बनाया जाता है? आप क्लिनिकल कंडीशन को भी मार्कर बना सकते हैं। आपके पास पल्स रेट हायर साइड पे, ब्लड प्रेशर लोअर साइड में है, सारी चीजें तो प्रेजेंटेशन है ही।
Again, think that systemic inflammatory response.
That is the better.
That is the marker of inflammation. It can happen in all the things. The TLC should be raised, the hypotension is there, hypoxia is there. So how can we judge whether it is the infection part or the inflammatory part? So when this question arises, we can take help of the procalcitonin. If it is also raised, then definitely we go ahead for the broad spectrum antibiotic. Otherwise, just manage conservatively without much of the use of antibiotics. So we can draw the benefit of this particular. It's not an absolute thing, but we can draw the benefit of this marker in the management, and we can salvage not only our antibiotic therapy, not only the nosocomial infection, but also the due course of complication in due course in the particular patients.
So now we'll take some questions from the.
In the treatment of pancreatitis, we used to see the pseudopancreatic cyst. How to manage and how to assist?
First of thing, the fluid collection and the pseudocyst. These are two different scenarios. Again, the duration is important. Any collection inside the body that is homogeneous is the fluid collection. Now, if the patient has evolved through the period of 4 weeks, 6 weeks, that it land up to the, we can say this is a pseudocyst rather than fluid collection. For all the fluid collection, we have to do nothing unless and until is giving the local complication, just like putting the stomach or the duodenal loop into the compression. So we have to put the nasogastric or nasogastric. For the real pseudocyst, we have to give the duration is important point. If 4 to 6 weeks still the fluid collection is there, then there is a pseudocyst there. Now whether should we treat or not is again the clinical part. If the patient is doing well, is not having any problem related to the pseudocyst apart from just fullness, we have to do nothing. Most of the time it resolves over the course of 2-3 months. But if the pseudocyst persists more than 3 to 6 months and patient is developing complication, then we have to treat. Again, the minimal invasive better method rather than the surgery. So this is important. Endoscopic pseudogastrocystostomy is now the method of choice rather than the open surgical, because it's a very minimal thing. And if there is an infection inside the pseudocyst, we have to put the large bore gap between the stomach and the cyst. Here the metallic stent or the lamps is important. Otherwise, if there is a persistent necrosis, inflammation, along with the infection, we have to do the necrosectomy or we have to do the direct endoscopic necrosectomy. So things are, again, the importance of time is very important in the management of pancreatitis.
कुछ चीज़ें हम जानना चाहेंगे, जैसे कुछ केसेस माइल्ड गेट तो परसिस्ट करते हैं, जिसमें एमाइलेज लैक्टेज मतलब नॉट मोर देन हायर लेवल दैट परसिस्ट फॉर so many months, so many years. In that case, what we should be our approach. Number 2, what is the role of pancreatic enzyme for the chronic pancreatitis? Now you have not touched the chronic pancreatitis, but what is the role of pancreatic enzyme therapy? Whether it is going to be help or suppress the inflammatory process? What do you think?
So, sir, very pertinent question. We see that so many patients, the amylase level is high. Most of the time, if the patient is not having any inflammation, we can ignore this point. The patient is clinically well, is not having any complication, local or systemic. Just by measuring elevated enzymes, we need to do nothing for these elevated enzymes. Say this, there are so many conditions where the enzyme levels are high. And again, second part is there for the chronic pancreatitis. Sometimes we see that pancreatitis is present, first time we see there is acute pancreatitis. The most of the in our scenario, the alcoholic pancreatitis itself, it has been found that most of the time patients do have the chronic component within the pancreas and then end up to the acute complication, acute pancreatitis. So how do we manage the chronic pancreatitis? Again, the symptoms govern the treatment. If the patient having any insufficiency, whether there is endocrine insufficiency or the digestive insufficiency or the enzyme insufficiency, just like the patient develop diabetes. So we have to tackle with the insulin therapy or whatever. But if the patient having the digestive insufficiency, just like in form of chronic diarrhea. So, and third is the pain. If the patient having persistent pain and the feature of chronic pancreatitis, then pancreatic enzyme replacement is there. So we have to give the enzyme therapy in those of patient for the pain management. And second is the chronic diarrhea itself. For the pain management, the enzyme should go before the meal. That's a very important thing. Pancreatic enzyme replacement therapy. We have to give the enzymes, prion or whatever the enzyme level is there before the meal, 15 to 13 minutes before the meal, and that should be uncoated. Because enzyme should reach the duodenum when the meal is reached. So, and there should be active in form. So we give the enzyme therapy uncoated form 15 to 30 minutes prior to therapy for the pain management. For the diarrhea management, we have to most of the time go for the digestive part. So we have to give the enzyme, entry-coated enzyme along with the meal, not before the meal. So we can tackle the digestive part. So same enzyme therapy, duration and coated or uncoated will change the management. For
ठीक, एक चीज़ और आपने बोला रिंगर लैक्टेट एक्यूट मैनेजमेंट में बेटर फ्लूइड है। रिंगर लैक्टेट और आइसोलाइट यंग में जो डिफरेंस है वो सब प्रोबेबली कैल्शियम लैक्टेट का डिफरेंस होगा, केवल उसी के लिए है। प्लस उसमें डेक्सट्रोज पोर्शन आइसोलाइट यंग में है, रिंगर में कोई डेक्सट्रोज नहीं है। तो ये सबका क्या मतलब एडवांटेज किस बात से ले, मतलब अगर आपने डेक्सट्रोज अगर नहीं दिया है तो वो इन्फ्लेमेटरी रिस्पांस को कैसे ओवरकम करेगा?
It has been not directly seen, but it has been seen the ringer lactate has some superiority over the other fluids. Again, the dextrose part is important because most of the time is acute inflammatory response, and most of the time the blood sugar level is most of the time raised because of this inflammation in the pancreas. So we have to cut down the sugar by the insulin therapy, and we see the blood sugar level is high in this patient. So giving added dextrose.
तो हफ्ते भर में नीचे आ जाता है।
So the initial management is for 2-3 more days. So initial management for first 48 hours, the ringer lactate is better because already the blood sugar is very high. Most of the time is high. So in that scenario, dextrose is not giving any advantage, rather than it is, may give the more morbidity to the patients.
Is there any drug to reduce the secretions of pancreatic fluid or enzymes? Suppose you have put a cannula and persistent secretions is there. Is there any drug to reduce the secretion?
Initially it was thought the octride, even the most of the time we do use the octride to reduce the secretions. But see how the whole concept is the pancreatitis is the injury direct to the pancreas. So there is a lot of vessels, there is a lot of inflammation is there. So we can't secretion by the gland or by ductular system. But the injury is directed to the pancreas. So the pancreas is injured directly. Enzyme is getting percolated throughout its boundary. So we can't reduce. If we reduce the secretion also, it's not going to change any scenario. So that's why in due course the octride therapy is not going to show any benefit regarding the mortality or morbidity. So it doesn't benefit by reducing the secretions.
So when we start oral therapy after IV, which food should be recommended? Which type of food?
First thing, as soon as the patient can tolerate and the patient is not having ileus, we should start feeding. It's a very important thing. And it should be given, most of the time is 3 days, 72 hours, because the earlier part, the ileus and the recurrent vomiting and pain is much more happen in the 3 days. After 3 days, if the patient, if tolerate, start immediately. Which type of food? We have to get fat-free diet, basically carbohydrate, simple digestible diet in form of juices or soups or like that. We have to start fat-free diet. That's important.
Thank you. I think there's a last question we'll deal with her. And now it's time for the presentation of certificate. I now request Dr. Shivshankar Shahi, our host of today's CME, to come forward to welcome our speaker with a bouquet and present the certificate to our dear speaker, Dr. Pankaj Kumar. A big round of applause for both of them. Dr. Shiv Shankar Shahi, the host for the today's CME.